My name's Carrie Siegel. I'm an abdominal radiologist at Washington University in St. Louis. And I have a subspecialty interest in GU imaging, but I do all aspects of abdominal imaging. So the question, what is a virtual renal biopsy and why is this important? So just a little background. When we see a solid renal mass on an ultrasound or a CT or MR, it's a really heterogeneous group of lesions that include benign tumors, most commonly an angiomyolipoma with fat or an angiomyolipoma without fat or an oncocytoma. Pseudotumors, which are things like columns of Bertin or areas of hemorrhage or infarct or infection that could look like a mass. Indolent renal masses that may be malignant, but if they're left alone, they're probably not going to have a major effect on the person's morbidity or mortality. And then more aggressive renal masses. So there's sort of a very heterogeneous group, and there can be significant overlapping imaging features when looking at this fairly superficially. Then if we take renal mass biopsy, which we've been doing for years, it's successful. And there are complications that exist though. Number one complication would probably be bleeding. And probably the number two complication would be either a non-diagnostic or an unclear report from the pathologist based on the biopsy. There's some accuracy issues with renal mass biopsy, both in terms of tumor, yes or no, but in tumor grade also. We're only about 50 to 75% accurate in terms of tumor grade. And there's a slight increase in upstaging due to perirenal fat involvement in patients that have undergone renal mass biopsy. So what is the virtual renal mass biopsy? It's where we look at all the different imaging features of the renal mass on all different types of imaging, predominantly CT and MR, and I'll touch on nuclear medicine very briefly. And all the different renal masses, although they have many similar and overlapping imaging characteristics, when you dive deeper, some of them have very specific imaging characteristics. Like, for instance, the papillary renal cell carcinoma tends to enhance very modestly, whereas the clear cell, which happens to enhance in a very hypervascular way. So those two are easy to differentiate, looking at the amount of enhancement compared to pre-contrast, or the amount of enhancement compared to the renal parenchyma, or amount of enhancement compared to the aorta, however we want to look at it. The oncocytoma is a problematic lesion for us on both CT, MR, and to be honest, sometimes for the pathologist on biopsy. Some oncocytomas have a very characteristic early arterial enhancement, and then they sort of dip down and they sort of hypoenhance later on. And people refer to that as segmental enhancement inversion. It's sort of a fancy term. The problem is not all oncocytomas show this, and not all radiologists can even agree on whether it's there. But when we look at some of these enhancement patterns, the attenuation on pre and post contrast CT, the attenuation curves, the signal intensity on pre-contrast MR, the signal intensity on post-contrast MR, the diffusion coefficients, and then some of these studies can be loaded into computer programs to look at what's called textural analysis. That looks at how smooth the tumor is and on a voxel by voxel basis, or how not smooth, how heterogeneous it is. And that can lead to one diagnosis or another. Angiomyolipomas that don't have fat, which represents about, 4 or 5% of angiomyolipomas, can have signal drop off on opposed phase imaging. That's where we do in and opposed phase imaging on MR. And we can look at that, and that can sometimes be helpful. So there's all these different criteria. And soon someone's going to develop a computer program where we're going to take our patient and load in, okay, on pre-contrast, the mass was 30 Hounsfield units. And on nephrographic phase, it was 70. and it was dark on T1 and bright on T2, and it had an apparent diffusion coefficient of this, and just load everything in, and it's going to tell us what's the most likely etiology of the renal mass. Are we exactly there yet? No, but we're very close. One other imaging feature that I want, or one other imaging test I wanted to mention is when we're looking at differentiating oncocytomas from renal cell carcinoma, some physicians are ordering a technetium-99 cestamide study. And that has been helpful in differentiating oncocytomas, which have similar uptake to or above, similar uptake to renal parenchyma or above renal parenchyma, where other renal mass lesions don't. So that's another test that could also be factored into this sort of virtual renal mass biopsy, where everything would be loaded into a computer, whatever the data we had, if you had a cestamide and an MR, or just a CT and an MR, and we would load all this information in carefully using all these different algorithms for all these different subtypes of tumors and come up with what's the most likely diagnosis. One of the reasons why this is super helpful is when we do a renal mass biopsy, we may not sample all areas of the tumor, whereas with a virtual biopsy, we're going to look at all aspects of the renal mass. This particular virtual renal mass biopsy will involve no additional time for the patient. It will involve additional time for the radiologist calculating all these different measurements and uploading them into a computer-based protocol. And sometimes in heterogeneous tumors, if one area looks much more worrisome or has much more significant diffusion restriction, if we are going to go to renal mass biopsy, we can direct somebody to a particular area of the tumor in the future. So these are some of the advantages of the renal mass biopsy as we move forward.